This is the medical report. We're very pleased today to have a discussion on back pain. And our guest is Dr. Schaefer, Matthew Schaefer, who is trained in physical medicine and rehabilitation and is the owner and operator of the management spine-related disorders practice, rehabilitation practice. You're in where? In Chester?
In Westchester and in Kennett Square,
yeah.
And soon to be in Jennersville.
All right. So with that, we'll turn it over to Dr. Schaefer, and perhaps he can explain to us what PM&R is, so our audience understands what your field is, and then we'll go from there.
Well, thank you, really, Dr. McCabe. Thank you for having me here, and thank you, Hershey's Mill, for listening to me. It's always a pleasure to be here, and many of you may know me already. So physical medicine and rehabilitation is been around for about 60 years. It's a medical field as opposed to a surgical field. So what we learn is how to care for patients without the use of surgery. And really that's what we're going to talk about today. What I want to talk about is the best, most research-proven treatment to relieve chronic low back pain.
Well, tell us a little bit about what physical medicine and rehabilitation training entails, so that these folks will know what your background is.
Sure, yeah. I can add a little bit more. So after 4 years of medical school, we do another 4 years, 1 year of internal medicine and 3 years of residency training program. I did mine at Stanford University in Northern California. And we take care of patients with really serious disorders, such as spinal cord injured patients, traumatic brain injured patients, but also many patients with musculoskeletal injuries, such as back pain, hip pain. And then from there, many of us specialize. So you choose the branch of medicine that you want to focus in on, and I chose spine care. And I worked at Stanford's Interventional Spine Center for the last year of my 3-year program. After that, I worked in what was the most prestigious spine care center in Northern California called Mount Tam Spine Center, where I worked with a surgeon and another interventional spine physician doing procedures like we're going to talk about today.
Very good. Can you tell us what some of the disorders are that you are dealing with primarily?
Right. So the main focus of my practice is patients who have chronic low back pain. And there are many causes of chronic low back pain. But what we've learned over really the last 10, 15 years, oh wait, it's 2017. So since 2004, we've learned that most of chronic low back pain in adults over the age of 60 comes from these lower joints in the spine, which are called facet joints or zygapophyseal joints. Or simply, we could just call them low back joint pain.
Okay. So what is the most common cause of this sort of thing?
Right. So the most common cause of chronic low back pain, not the acute onset pain when you just bend over and have back pain and that goes away in a week or two or a couple weeks. We're talking about back pain that's been present for months or maybe even years. And it's that daily pain. And the most common cause of that really is the lower joints in the spine, which are termed medically zygapophyseal joints, but we call them facet joint pain. Other causes of joint pain or low back pain, are the sacroiliac joints, and that's a common cause. The discs, discogenic pain, and in the aging population, spinal stenosis, pinched nerves, sometimes tears in the discs.
All right. So if somebody has, say, spinal stenosis, which I know is one of the more common issues that you run into, especially in the older group, what do you have to offer these folks?
Well, we actually talked about spinal stenosis in a different lecture that I think many of the patients here at Hershey Mill have seen. But briefly, epidural injections, physical therapy, manual therapy, certain modalities can help with spinal stenosis type of pain. And ultimately, the only fix for a mechanical problem such as spinal stenosis is surgery, is opening up the stenosis, otherwise known as lumbar decompression.
Okay. With sciatica, which is a very common term people use, what is sciatica?
Well, sciatica is actually a misnomer. It's used to describe pain radiating down the leg, usually past the knee, usually down the posterolateral portion of the leg. And early anatomists found a big nerve, which they had labeled the sciatic nerve. And that nerve comes out of the buttocks area. And they thought that that nerve was causing most of this pain. But it turns out that that nerve usually is not, that nerve in and of itself is not the cause of pain. The pain is from the nerve roots that make up the sciatic nerve, namely L4, L5, S1, and S2. So those nerve roots come out of the spine right here, L4, L5, S1, and S2, and they form together really two nerves, the peroneal nerve and the tibial nerve, wrapped in a sheath. We call that nerve the sciatic nerve, and sometimes it can get pinched as it comes through the muscles here called the piriformis muscles. So most of the time the term sciatica is used to describe pain radiating down the leg, but most of the time that pain is not from pinching of the sciatic nerve, it's from pinching of a nerve root, usually L4 or L5, and it's more appropriately termed radiculopathy.
Mm-hmm. So what Dr. Schaefer is talking about today are what we call non-invasive procedures, that is non-surgical procedures for the correction of these disorders that he's describing to you. Can you tell us what some of the treatments you have that are non-invasive?
Right, well, I'm excited to talk about one particular treatment today called radiofrequency neurotomy. And this treatment, which I said at the beginning, is really the most research-proven, best treatment to relieve chronic back pain. And the reason for that is that most chronic back pain in adults over the age of 60 is coming from these joints in the spine. And most of the time, it's the bottom 4 joints in the spine. And these joints are termed facet joints or zygapophyseal joints, and they are true diarthrodial joints, just like a knee joint. They have a capsule, they have cartilage, and they are innervated by little nerves that allow them to hurt. The joints can become and do become inflamed. They can get fluid in the joint. The joints get arthritic, where the cartilage wears off. That really is the most common cause. There is an often quoted research study by Dr. Schwartzer, which was published, I believe, in, let me get this right, I think that was 1994, that's a long time ago. 1994 that was published, and he showed that 40% of chronic low back pain in patients over the age of 59 was coming from these joints. After that study, another study was published that showed even more than that, even more than 40%. 60% of chronic low back pain was in elderly patients or aged patients was coming from these joints. Now, this type of back pain is not just in people older than the age of 60. 15% to 20% of chronic low back pain has been shown in younger patients below the age of 50 to be coming from these joints here. So what I want to talk about today is a procedure where we remove the innervation to the joints. Before I get to that, though, I did want to talk about the symptoms of the facet joint pain, how you know you have it. So I was hoping to bring in a model. Is that okay?
That's fine.
Okay. So why don't you come on over here, Valerie, and maybe face that way. So typically a patient with facet joint pain or low back joint pain will have pain in the lumbar region of the spine, and they often put their hands right there and say, that's where it hurts. Sometimes the pain radiates a little bit lower down into where the sacroiliac joints are, and it's often mistook for SI joint or sacroiliac joint pain. It's rare that the pain radiates lower down into the buttocks or posterior thighs, like from spinal stenosis, but it can. It almost never radiates past the knee. And when you present to the spine care physician, or at least when you're in my office, I do some testing, physical exam testing, to make me more secure that the joints are the cause of the pain. And one of the tests that I do is a rotation and extension test that I will demonstrate. So what I do is I take the patient and I bend them one direction and extend them back. And I ask if it reproduces their pain. In effect, we're loading these joints right here. So if the joints are hurting, that would usually make the pain worse. I do one side and then I do the other side. And so if I can reproduce some of the back pain, that's an indicator. I often have the patient bend over forward and want to see if the pain feels better, and that's a common sign of facet joint pain. It feels better when they bend forward, when the patient bends forward. Let me turn the model to the side because she is actually a good example of a condition that may predispose to having facet joint pain. And that condition is this increased curve here that we call increased lumbar lordosis. And that curve allows or causes much of her body weight to be carried across the posterior elements or these facet joints. Okay? So if you're carrying most of your weight across these little joints here, they often become inflamed and they hurt. I will not demonstrate this now, but also in physical exam, I have the patient lie down and I press directly on those joints, trying to figure out which of the 10 lower lumbar facet joints are causing the pain. Thanks, Valerie. So that's how we begin to diagnose this type of pain. The next step comes a small diagnostic procedure where what I do is I either anesthetize or block the joints that I think are causing pain. So I'll put a needle using live X-ray or fluoroscopy. I'll put a needle into a joint and I'll put numbing medicine, much like at the dentist who numbs up your gums, in the joint. And usually it's the bottom two joints that are the instigators. So I'll put some anesthetic or numbing agent in those joints, and then we'll see how the patient does. If the back pain goes away, that's a pretty good indicator that those joints were the cause of the pain. If the back pain does not go away, then most likely those joints are not the cause of the pain. So if you pass the first diagnostic test where the pain went away for a short period of time by anesthetizing the joints, the next step, which is really more research proven to be absolutely certain that these joints are causing the pain, is what I do is I actually block the nerves that supply the joints. And in this region, the nerves are called the medial branch of the dorsal ramus. And they are little nerves that come off this big nerve root here, and they wrap around the junction here of the superior articular facet and transverse process, or this bone, this little junction, and it will innervate the joint. And each joint is innervated by two of these little nerves, one from the level above and one from right at that level. So what I do is I put a needle in and I put a little bit of numbing medicine right in the corners here, right where those nerves are, and I numb up the nerves. So if I numb up the nerves that supply the joint and the pain goes away, then I'm relatively certain that if I put little holes in those nerves or ablate those nerves or destroy those nerves, that the pain will go away until the nerves regenerate, which is thankfully a long time. So the procedure is called radiofrequency ablation or radiofrequency neurotomy or heat neurotomy or RFA. There's many different names. It used to be called radiofrequency excuse me, radiofrequency rhizotomy, but it's not really, that's another misnomer or misname because it's not a nerve root ablation. So we like to call it radiofrequency neurotomy. And I do this procedure in a surgery center where we keep the patient very comfortable because we're able to use anesthesia. So the patient has light anesthesia, and then we numb up the skin in an operating room, and we give the patients I call it the cold bath. We clean them up and sterilize the area, and then we numb up the skin with lidocaine. And then after we numb up the skin with lidocaine, I use a live x-ray called fluoroscopy to image this area right here. And then I numb up the tract that I'm going to put my needle in. And then I place a needle right at the junction of the SAP and transverse process where the nerve sits. And I then put an electrode through the needle. And it's about the size of this pen tip. When I poke it out, I don't know if you can see this, but like this. It's about this size. And that electrode forms or releases energy, okay, that oscillates in the same or very similar frequency to radio frequency waves, and that's why we call it radio frequency ablation. And that creates energy and heat, and that energy and heat in effect burns away the little nerves that supply the joints. So I have to leave this electrode here for about 90 seconds, and I typically do 1 or 2 spots at each level that I want to get the nerve. And the procedure usually takes about 30 minutes to do, so it's not long. And like I said, the patient has anesthesia, so you really don't feel much. And then after I do each of these little nerves, the patient presents to the post-op area, and we ice the back for about 15-20 minutes. And usually the patient goes home comfortable because we put a lot of numbing medicine in. And then over the next couple days, the little bit of soreness goes away from the procedure, and the joints can't hurt. They cannot hurt because the nerves that supply the joints have been disrupted. And the good news about this is those nerves take a long time before they grow back. If we look in research, those nerves on average grow back in 1.5 years or 18 months. So what we're talking about here is your maybe 10-year history of chronic low back pain, the pain that bothers you every day. When you go to get out of bed, you have that ache. When you're standing in line at the supermarket, your back is aching. That pain is gone, and many patients find they get their lives back, and they're able to start exercising and walking and get healthier because their back doesn't hurt. And they're pretty happy when it doesn't hurt for 1.5 years. Now, what I found in my practice, and I've done this procedure off and on for 20 years, and I've done quite a bit of it over the past 7 or 8 years. I went back and saw that I did over 500 of these cases. And what I found is that my results have been variable. I've had patients where the pain relief has been only for 6 months. But I've had patients that told me that I just saw a patient that told me that he had pain relief for 4 years, and he thinks the only reason why his pain came back is because he got in a motor vehicle accident, and that flared the joint pain back up again. This procedure can be very effective in taking care of long-term chronic back pain. I know I just focused on this one procedure, but many of you may have had the steroid injections in your back, and that has been commonly done by many different doctors, and many patients have had what are called facet injections or steroid injections in the back. And those injections, the problem with those injections is that the pain relief usually is transient. So another procedure that gives shorter acting benefit is just called facet injections or steroid injections. And in that procedure, all that's done is the needle is placed into the joint, and we just put a little bit of numbing medicine and steroid in the joint. It does nothing to disrupt the nerve supply of the joint. And what we know about steroid injections, and many of you might know, because these injections are done in the knees, the hips, the shoulders, that they never last forever, and they usually don't last a year or 2 years like a facet radiofrequency neurotomy procedure will. So I know I can get going on a roll and start talking kind of fast sometimes, so I'm going to stop now and see if Dr. McCabe has any questions for me.
Well, I think I might have a few. One of the things we oftentimes tell patients to do is to exercise. I was taught that if you look at somebody on the side and they have one of those abdomens that goes out like this, they have a pelvic tilt, so that their center of gravity is thrown off. And this is the cause of some back pain. Is there any truth to that?
I'm really happy you brought that up because that is one of the common findings that will cause facet joint pain. If there is a pendulous stomach, you've had a little bit too much to eat over your life and the stomach has gotten out of control a little bit here, that can cause the pelvis to tilt forward, and in order to prevent you from falling on your face, you have to extend back and lean back. And when you extend back and lean back, you're loading the facet joints or zygohypophyseal joints. And there was a research study that showed that patients with chronic low back pain, they carry 2/3 of their weight across these joints, or what we call the posterior elements, or the back of the spine. And patients that do not